response to intervention, right? And determining, if the patient is truly improved or not, and if not, is this a reason that we need to be concerned about something else kind of going on? And what I'll present to you, I thought this was an interesting study. So it had a really kind of a cool name, the SPORT trial. And what it looked at was patients who had radicular low back pain due to what was thought to be large herniated discs in the lumbar spine. And if you look at, so they had to have a hard neurologic finding, like a hypo or absent reflex. They had to have weakness, they had the sensory deficits. And then they had to have a herniated disc that was either classified as a protrusion or an extrusion. And these are normally, patients that get excluded from studies, but 2/3 of these folks had those large herniations, right? And about 25% had protrusions, which is kind of the next step down, and then sequestered discs, right? So these are folks that had, herniated discs on MRI that we thought to be causing these radicular type symptoms. Now, the study's a little bit tricky because if the patient became progressive, where they needed surgery, right, then they kind of opted out of the study, right? So, because if you have patients with neurologic findings and these large herniated discs, there is a time and place for surgery. There's a time and place for surgery. Right? And so, what I'm going to look at though is the outcomes. And so, one group got these microdiscectomies at the appropriate level, and the other group got this non-operative approach, and it could be anything. It could have been chiropractic, could have been PT, could have been primary care, could have been anything, right? And it wasn't standardized. The study was basically, Dr. Weinstein, he's the editor-in-chief of Spine Journal. Not Spine, so there's a thing called Spine, but it's Spine. Probably the top spine journal, probably in the world, right? And there's a bunch of really, really sound researchers and physicians on here that looked at the study, and I think the study was with the name. The study was really set up for success on the surgical side. Okay, that's what it really, in my mind, that's what this was set up for. If you look at the outcomes, okay, so the outcomes here, the two on the left are bodily pain and physical function. Remember I mentioned that SF-36, which is really more of a research tool. There's 4 domains under physical function, 4 domains over mental function. And these are 2 that they looked at here, bodily pain and physical function. The higher the score goes, the better you get. And then on the far right is the Oswestry score. Okay, the Oswestry score. And I don't know if I got a copy of the Oswestry either. Is anybody using the Oswestry? Does anyone use that? KG's shaking his head. Does anyone else use it? Show hands. Folks are using it. So there's 10, I don't know if folks are familiar with it, I don't have a picture of it, but there's 10 different areas of function. And you score them on a scale of 0 to 5, right? So you come up with a score of 50, and you double it, right? And then you look to see what that score is. And so this is what I'm most familiar with, and I look at that scale on the results on the right-hand side. Now, what shook out was there really wasn't any difference. You can see the lines. The lines are really, really close. There really wasn't any difference in terms of outcome with the group that got conservative care versus the group that got surgical care. Okay, but let me ask you this: did these patients actually improve? And at what point would they tell you they're improved? Okay, because they could follow up 24 months. The reason I bring this up is that I would ask you that how do you know the patient that you've seen is actually successful in terms of outcome? How would you define it? Yeah, they go back, I remember hearing you talk, and I think he even wrote an editorial. Tony Polito, who's one of the folks over at University of Pittsburgh, said that as PTs, and I kind of took it to heart, that we should be calculating our quote-unquote batting average. Right? How many of the patients that we see, let's say with acute low back pain, actually have a successful outcome? How many of the patients that we see with radiculopathy, with a large herniated disc, have a successful outcome? And it comes really to determine, like I said, response to intervention is some of the things that we use sometimes to determine if patients need to be referred. Does anybody have any indications of how they would define a successful outcome? How do you know when your patients are better? You probably ask them. Well, function, do you have a metric that you use? So what I would say, and I'm not making this up, so if you look at the literature, it's typically a 50% drop in the Oswestry score from where they start, right? So if these folks are starting, this is probably around 48, right? So a drop of probably somewhere, probably around maybe 20, 24. After that, you could count that probably as successful outcome, meaning the patient is down below that. And we follow probably around 3,000 patients in the military with this Oswestry instrument, and we try to figure out at what point in the score do they start to tell us that they're able to get back to high-level activity, and at what point in the score do they tell us that back pain's like that the number one thing in their mind. Right? These patients up here, close to a 50, how do you think they're going to feel? First off, anything less than 20 is classified as like mild disability. 20 to 40, moderate. Anything over 40 starts to get in this window where this is going to be the number one thing on their mind. They get up out of bed, it's the first thing they feel. It's there. It was there. Right? So what we found was that when they start to get down below 20, most of these patients you're going to see that you see in PT are probably going to be somewhere around probably 40 if you use the instrument. Around a 40 to a 50, maybe sometimes lower. But once they get down below a 20, they're going to start to tell you that, you know what, I'm really starting to feel better. Once they get down below like 15, the near between 10 and 15, now they're going to tell you, you know what, I can go back to the gym, and I can get back to work, and I can start doing physical things again, and I'm not worried about my back bothering. So at what point did these patients, we use those metrics, at what point did these patients get better in this study? What do you guys think? Based upon this data right here, here's the Oswestry score, and then here's somewhere between 3 and 6 months. Right, somewhere between 3 and 6 months. And so, now first off, there was no difference between the groups. Now, is anybody kind of surprised by that? You know, and they say, if you read the paper, right, again, these are all surgeons on here, right, and they say that if you want to get better quicker, right, you should have surgery. Right, they even had an editorial that if you were, you know, labor or if you want to get better quicker, you should have surgery. I don't think that pans out. You know, we look at the differences between these groups. It's a couple of points at each point in time from a mean perspective, right? And I know that, you know, I listened to one of these podcasts about clinical prediction rules. They're really getting a bad name. But the reason I think clinical prediction rules are sometimes helpful is that within these patients, you had several patients who really got better a lot. You had several patients who didn't get better really at all. And then you had some kind of in the middle. The clinical prediction rules are helpful because they tell you what some of the predictors are for some of those subsets of the population that really got better or didn't get better. And that's helpful from a prognostic perspective. Anyways, no real difference between the groups. Mike already mentioned this, that when you start to look at these large herniations, in this case, this is a sequestered disc with an extruded fragment here. Here's a sequestered fragment, here's an extruded disc here. This was a study that looked at the regression of these large herniations over time. And what they found was by 6 months, you know, you can see the sequestered fragment is gone, and the disc has resolved significantly. Disc herniation resolved significantly. And they talk about, you know, what some of the rationale for this probably is. There's something that probably goes on with some of these white blood cells that begin to act on that. But anyways, this is a true phenomenon. This could be part of why I say that. So if you have a patient who is, you know, truly dealing with radicular type symptoms, hard neurologic findings, if they can hang in there, right? If they can hang in there, they're probably going to be okay, right? But what's the period of time that they have to hang in there for? So this is one of my concerns with some of the data that we have. There's a mismatch in expectations. When do patients want to be better? Let me ask you that.
Yesterday.
Right. And when are they going to be better? Yeah. No expectations here, right? You have to let people know. This is the deal. So you know, I don't know how thorough you guys are with your subjective exam, but one thing I got from this program is that that subjective exam is probably the most important component of anything I'm probably teaching. And I would say, you know, all these places have utility, but this patient profile is extremely important. I'm getting into the weeds now on what questions are probably important. So regardless of where I present this, I always have this picture in here. I think you might have been doing clinical supervision on me. A guy with knee pain that would walk this.
Yes.
And he was a quality engineer who would walk the things. And I can't even stand at this table with the fear of heights. I think we did mobilizations on this.
You did,
but
yeah.
It was good. But that's why I put that in. This is the bottom line. So patients come in, they're going to tell you they have limitations in their occupation, or they have limitations in their hobbies or recreational activities. And that could be recreational sport. I think the most important thing to know is what their current restrictions are, and what are they hoping for with regard to expectations on recovery. And it also includes a time frame. Right? It includes a time frame. And so when a patient tells you, this is where I'm functioning now, this is where I hope to get to, this is the time frame, right, that I want that to happen, what's your job? What's your job at that point? Is that feasible? Is it feasible? And that's a hard conversation to have, especially when you don't think that's going to be feasible. If you don't have that conversation, what are you setting that patient up for? Failure. We just started a rotation with our students with the Buffalo Bills. So they've been there about a week. And I talked to the kid last night. I was in the airport. He said, can I just talk to you for a second? So we have two students who were there. And what he got out of this was that, so they're done with the season. And so they have folks in their practice squad who were put there for injuries. And they basically have a conversation. It's about 5 minutes. You know, you tore your ACL. You know, you injured your shoulder. You know, we don't think you're ever going to be back at the level you're at. You're done. And they're making the students have these conversations. And it's not the kind of kid who'd be easy to do that. But he said, you know, it's just completely matter of fact with these folks. So you're a 25-year-old professional athlete, and you're done. And so who's going to have the conversation with them that it's over, right? And so I'm not saying you have to get to that level, but again, understanding the restrictions, understanding what their expectations are in the time frame, and then you look at history, physical exam. Does that seem reasonable? Right? Does it seem reasonable? Because I think these patients want to be better yesterday, and they're not, and they get frustrated. And is there improvement this shape? Is that how typically a course of care goes? It's all over the place, isn't it? But eventually maybe it makes its way down. But they're going to have setbacks, and they're going to have concerns with that. So again, if you're spreading your 5.5 visits out, because I think that I need to let these patients know that are chronic like this kind of profile, I don't think you're going to see any real change probably in 3 to 6 months. I'll be completely honest with you. If you do, that's great. But we need to hang in there for that period of time, and we're going to work together in doing that. And there's going to be times when you're feeling better, times when you're feeling worse, and that's where we can work with you to help you through that. Okay, so that expectation is important for this. I think these patients are set up for failure because they don't have that conversation early on with them. Those are two important things that I think we need to talk about. Different population here. These are patients that have acute low back pain, right? They have pain for less than 16 days, right? And they have no symptoms below the knee. A very different population. One group was managed by a primary care physician. One group got 4 PT visits. Okay. Now, what would you expect in terms of outcome in this particular study? These patients with acute low back pain. And they were managed with thrust manipulation, followed by a stabilization program. 4 visits. So here's the data here in the entire read. These are Ross-Western scores. So baseline score is about a 40 in each group. Here's the 4-week score. 14.5 in the usual care group, 11 in the early intervention group. I'll ask you, are they better? Are they going to tell you they're better at 4 weeks? These patients are better. They're improved. You know, it's rare that you get patients down to a 0 on those X questions, right? So they're better. Is there any difference between the 2 groups? Probably not. There's a 3-point difference. It shouldn't be significant, but that's really no difference between the 2 groups. But my point is that if you're seeing patients with more acute symptoms, what's your expectation for improvement? Much shorter period of time. And again, these patients who are chronic, you know, when you start thinking about medical screening and sinister findings and red flag pathology associated with their clinical condition, much of that would have shook out a lot earlier, right? So you can feel comfortable with the fact that you're going to maybe treat them for 4 weeks and they may not have a huge improvement. But these folks that are acute, much different, right? Because those are the patients who sometimes get in trouble. Patients who are acute, you should see significant effect sizes early on in the course of care. Okay, we good with that? And then, so the one thing they mentioned, this is Julie Fritz, who's just, you know, I don't even know what to say, this outstanding researcher, great. The one thing they did say is that there could have been patients in these 2 groups that if they stratified them or evaluated them, that may not have even needed PT. There's probably a group of patients that we can probably see with acute low back pain. I remember this from my days in the military. You can see them for 1 visit. You might do some manipulation with them. They get up, they're better, right? Whatever that comparable sign was, they're better immediately. You'd almost know that, you know what, I probably don't need to see you again, but here's my card. If you're not truly better in a week, 100% better in a week, call me, and we can see. And I remember a handful of patients, not a handful, there were a lot. We had like a low back month, 7 o'clock in the morning, you'd see these young active types who had low back, right? So cases that you can tell that may not need extensive intervention, right? So she mentioned that, what if we had screened them with the start back? I did ask Dr. Chow about this. This has been something that is shown to be very, very beneficial in stratifying patients and how they should be managed in other countries outside the United States. It hasn't been shown to have as much benefit here, and I'm not sure exactly why. Are folks familiar with this stuff? Who's familiar with that? I'm just showing you. Okay, so you're not raising your hand. But this is a tool that we use with these physician groups and young physicians that are coming out to say, well, who should we send to PT? And so what they do is they complete these 9 questions. And if you look at the first 4 deal with physical function. Questions 5 through 9, right, deal with some of these psychosocial issues. And then you score. And if the patient has 3 or less folks score, they're low risk. So what does that mean? When you look at the management of these patients, it's what I just said. It's like 1 visit, right? 1 visit, it's advice, it's education, might be some manual therapy, it's some exercise prescription, talk to them with prognosis, and they're good to go. If they have a total score of 4, right, then you look at the psych score. If they're 3 or less there, they're medium risk. So what does that mean? That's the group that needs the 5.5 visits. They need to be seen by a PT, because this group right here can be managed by those physicians. You know, they may not do, but they always want to know how to, they always ask, you know, can you teach us some of those techniques? Maybe they'd like to do it. In one of the schools we did it was an osteopathic school, which I can tell you. I worked with them in a pro bono free clinic that taught, you know, that treated folks without insurance. They just lumped everything. Absolutely no screening. High velocity rotational thrust, they just went off. Like, and I'm like, oh my God, grab it stuff, just go with the towel. But that's really day and time. So if they have 4 or more, 3 or less, they need a course of no pity course of PT. And if they have 4 or more on the psych score, now they need this psychologically informed care, right? So now you're dealing with folks who have yellow flags, that your management strategy probably has to change a bit. And if you did nothing more than take a look at this, even as a PT, just to say, if I have a patient who's here, right? These are folks, and what this risk means is that they're at high risk for chronicity, right? Those are at higher risk for chronicity. And so these patients here who are at high risk, who need that psychologically informed care, you may not know how to do that. But there's folks that you know here that might be more apt at treating those patients and more confident treating patients. But I'll talk to you about it tomorrow. You know, I'm no expert at it. You know, we see patients at that high risk all the time who have yellow flags, and it mostly is about, again, setting expectations, making sure the patient doesn't have a red flag condition that would cause them to not want to move. So I used to use this example when I would test the students. I always had a patient in there who was, it was an 80-year-old woman who was osteoporotic, long-term use of corticosteroids, low bone mineral density, and she reaches into her trunk, feels the snap in her back, and she has 8 or 9 out of 10 low back pain or thoracic spine. I'm trying to paint the picture of a compression fracture, okay? And then I ask them, given their yellow flag profile, because they now have yellow flags that they want to avoid movement, you would now implement a cognitive behavioral approach to movement strategies. True or false? They have a compression fracture. Should she be moving? Do I need to turn into Dr. Phil? No. There's reasons that patients wouldn't want to move. That would be an example of, let's say I'm treating a patient who has an inversion ankle sprain. They meet the auto ankle roll. I do a x-ray, and they have a fracture of their lateral malleolus. Is there a good reason for that person not to want to bear weight and not play sports? Or do I need to turn into Dr. Phil? Your body's strong. You like to treat it. So really, really neat. You throw weight on that ankle, and pain doesn't mean harm. Pain doesn't. Certain patients. I'm serious, because you know, cancer, infections, cauda equina, hard neurologic findings, are reasons that patients may not want to move. And so you've done your due diligence and you've screened for those, and you're saying that I can teach you how to move, despite the fact it's going to be painful. Because the more movement that you do, and you don't feel substantially worse, now you become more confident in those movement strategies. You guys follow me? And you guys prescribe the movements that are going to do to make them more confident. That's just, you know, 30,000 foot view. And then all this shows you here is that what the outcomes are, and you can see that these differences between the groups, when you screen these patients out, you treat them in the manner that they should versus everyone getting the same thing, there are differences between the groups. And all this shows you down here that these high-risk patients, right, those are folks who need that psychological informed practice. And the low risk that you're see at the bottom here, these are folks that just need advice, reassurance, right, and let them know that they're not getting better to come back and see you. But it's shown out to be pretty well. And I asked Chow about this, and he's like, I said, is it fair to use it? He goes, it absolutely is. He said, but you know, physicians have a hard time because they think it takes time to score. There's 9 questions there, right? And we've implemented our Catholic health system there, and the nurses score physicians. And what we think is that the patients that are getting triage to PT are probably now more appropriate by using this than before we use it. So take it for what it's worth. But I say at the very least, go back to those clinical practice guidelines, they recommend at least doing some screen for yellow flags. And we'll talk more about how you can even make it even more basic. Talked about this already. Patient values, you guys know what these are, right? But it's important that, and this is the key, you're in the middle of a busy clinic day, you get a challenging patient, and you know that you don't have the time that you probably need to give them. I think that's when you need to identify that and probably step back a little bit and figure out what can I do for this person and what do they need, right? Because that's when things sometimes kind of get missed, right? You're running behind a little bit, you're going to be a complicated patient. Not all patients need the Cadillac approach all the time. Right? There's some patients you get away with doing a little bit less. Those patients that need more, okay? And then again, when we start to talk to these patients, our goal is to try and get them to be truthful with us, because we need truthful information in order to guide our interventions, especially in terms of medical screening. So this whole business of communication and confidence is going to be important in gaining their confidence. And I think that, you know, I think we've struggled with that. I don't know about you guys, but it's a struggle. I've talked to a lot of patients for a long time. And, you know, when you start asking patients, are you satisfied with the care that you received? They're not, and for some of the reason, it's just that those kind of things broke down. We already talked about that too. Looking at patient expectations, what's a realistic recovery in your mind, for what period of time, and then trying to determine, is that fair? So we're going to spend the majority of the rest of today and tomorrow, right? We've already talked about the history a little bit, and now we're going to work our way through all these things right here, ultimately determine, is the patient in the right spot? Right? Is the patient in the right spot? Is this a patient that I can comfortably treat? Or is it a patient that I can treat when referred for some other reason, or refer only? And treat and refer could be a patient that identifies some concern with depression that's unrelated to their condition, right, musculoskeletal condition, and now I'm going to refer them out for treatment for that. But I can continue to treat their lumbar spine, treat their neck, treat their shoulder, right, and then we follow up on it. There are other patients that are going to be referral only, right? So if I'm dealing with a patient who has true suicide, a couple conversations, that therapist probably should have referred them because they had suicidal ideations. You can talk through some of that, right? And sometimes there's therapists that are a little bit better at it than others, and that was a good therapist at talking to patients and feeling comfortable. And I think when I asked him, I said, if she wasn't seeing a physician the next day, would you have possibly called someone about those suicidal ideations? I said, I think that if she got worked up by the cardiologist and this went the direction that I thought it was going to go, I thought that depression and the suicidal ideations would definitely tail off because it was related to her condition. But what if he made a mistake and she was truly suicidal and something happened? Right? So that's an indication of why you refer home. Right? If that's there. So we're going to get into this concept of differential diagnosis for the remainder of the course, right? And you guys know what this is. It's comparison of symptoms of similar diseases and making some decisions based upon whether or not the patient's in the right spot. We've already talked about that hypothetical deductive reasoning model. Then we're gathering data, and do we support or refute our hypotheses with the data that we gather? I mentioned this too. I used to include this paper as the pre-course read, but you guys like to read this stuff, so I didn't do it. Just left you a little one-page thing about the little kid with Down syndrome and the paper about the patient with claudication. But this is a good graphic, okay? Because, you know, from the time you lay eyes on a patient, you're developing what's called a pretest probability of a condition. Right? You're going to gather critical examination information. Again, history, physical exam, response, intervention. At some point, right, you're going to reach this action threshold. You're going to decide, is the person in the right spot? You'll never probably be 100% sure. Because we don't have those gold standard diagnostic tests that are disposed lots of times, so there could be some uncertainty. And I've showed you several cases already today that had lots of uncertainty. First patient, right? Hip lumbar differential. Second patient, right? The smoldering cardiovascular disease, right? And so you're never going to be 100% sure. A couple more cases here, and I want to talk about neurologic examination, neurologic screening, and we'll kind of see where we're at. So, interesting case here. Some of you may have seen this already, but if you have, just hold off. Maybe some folks have. But 32-year-old woman, 22 weeks pregnant. She's coming to see a PT because she's had what she calls this nuisance value low, she calls that. It's this nuisance value low back pain, right? When she stands, right, and she walks, or she's preparing a meal at the counter, or she's working in the kitchen sink, or she's vacuuming. Extension-related, activity-related low back pain, intermittent naked or lumbar spine. Right? She's proactively consulting a PT to determine if these symptoms are going to get worse over time during pregnancy, and if so, could she do anything to prevent it? Fair, right? Fair. Right? In the military, every woman, right, got a visit with one of our female health therapists or some of our other therapists during that time, right? And then immediately after they delivered, they did that again as part of their care. I don't know if that happens everywhere, but this is not a bad thing that happened here. When you look at her past, she was diagnosed with spondylolisthesis at age 18. So she fell out of a tree. When she was 13 years old. Hurt her back. Dealt with back pain, significant low back pain all through her adolescent years. Finally had an X-ray at 18 where she said, I had this spondylolisthesis. She's had normal back pain over the past 7 years, but she does have this intermittent ache now that's related, she thinks related to her pregnancy. And do women who are pregnant develop low back pain? Yes, they do. So this is nothing new. Clinical exam was completely benign. She wasn't having any symptoms. So she had a normal neuro exam, and she had pain-free lumbar active range of motion. And so everything shook out normal. Now, I asked you here what the next step would be. I'll say this, I presented this case a lot over the last several years. And when I present it to PTs, what do I normally hear what the next step would be for her?
Treat.
What would you do? What's that? Lumbar stabilization. Is she probably going to have increased back pain over time? Probably. Probably let her know that. There's good reasons for why that's going to happen. Would we maybe teach her some strategies that might mitigate some of those symptoms? We certainly could, right? And that may be all we do, right? Maybe continue to follow. Would anybody do anything else? And I had some coffee at the break, and they're like, paraphrase, we got a lot that we already got to do. And you're asking us now, in addition to seeing our patients for their musculoskeletal disorder, do you want us now to screen for depression? Do you want us to think about cardiovascular disease? Do you want us to think about diabetes? Do you want us to think about sleep hygiene? Do you want us to screen for general health? Yeah, I think we can. I don't know. What do you guys think? I think we can do something. I'm sure, I'm not talking about little things here. This is cardiovascular disease, which continues to get worse. Diabetes, which continues to get worse. Depression continues to get worse. That truly affects the quality of patients' lives. We can do what we do really, really well, but we can also get these folks off to the appropriate provider. So yeah, I am asking. But for her, again, this is a PT again, who's probably going above and beyond. He asked her, have you told anybody about respondylolisthesis? Well, who do you mean? Well, did you tell your obstetrician about this? Your obstetrician was going to deliver the baby. So that can be a lot of different ways, but the obstetrician was deliver the baby. And then he asked, well, did you tell the anesthesiologist? Because she already had her anesthesiology visit. She was going to have a epidural to control her pain during pregnancy. And they didn't ask, and she hadn't told them. Now, why do you think he's asking that question, PT? What do you think a contraindication would be to sticking a needle into somebody's spine? Just sticking a needle into any joint. You're trained to inject those needles based upon normal anatomy. Abnormal anatomy, things start to change, right? So spondylolisthesis with that abnormal anatomy could potentially be a precaution, if not a contraindication, to an epidural injection into the spine. At least they should know about it, right? So they didn't know about it. So again, PT going above and beyond, he calls the obstetrician, says, I'm seeing Mrs. So-and-so, he didn't even know she was seeing me. He said, oh, by the way, she mentioned that she has this spondylolisthesis. Next question from him was, does the anesthesiology staff know about that? And they don't. And so they thought it might be best to get diagnostic imaging for her to see what this looks like before they start monkeying around. And now, all of you have probably been around this, but you know, there's a couple of real traumatic times in my life. And one of the most traumatic times was when my ex-wife gave birth to her first child, our son. And good old Mike Tyler was like 3 weeks overdue, and she was induced. And it was hell's bells. It was like a freaking war zone in there. She called me names and looked at me in ways that I never thought I could be looked at. Blood everywhere. I remember Letterman was on. We got there at 6 o'clock in the morning. Dicked around the whole day. They put this Pitocin drip in. Contractions started, and she was going to go, oh, I'm going natural, right? So these contractions started. Doctor couldn't figure out where to put the needle because she's having these contractions. Doctor comes in, I remember his name is Dr. Cusick. primary care doctor delivered baby, shows up. It was, on December 29th, and a couple days, came in, I think he had a couple cocktails, he was on call. This guy playing with his mustache, watching leather and just laughing. While all this is going on, I'm holding in front of me. And I'm like, this is a disaster zone. And so my point is that, things can get kind of hairy in those types of situations, especially when you start thinking about pain management. And so if we wanted to examine her lumbar spine, what imaging could we do to determine if there's a spondylolisthesis? What could we do? Good things to know here. Could we do an X-ray with her, a radiograph? No, that would be contraindicated. Would an X-ray show if a spondylolisthesis was present? Yes. It would, and that would probably be the first place you would definitely start. Right? AP in the lateral and the cone view would be a perfect place to start. Can't do it with her though, right? And so again, before you refer a patient off, especially if she's a young woman of childbearing years, refer for imaging, you should probably ask, is there any chance you could be pregnant? Most of these centers now check for pregnancy tests, right? Because all you need is one to slip through the cracks, right? And can you do a CT scan? Would a CT scan show if there is a spondylolisthesis present? It would. Can you do an MRI? You can do an MRI. Now, do we truly know if the MRI doesn't use ionizing radiation, but has the study been done to truly show that it's safe on babies? It's not. I'm like the co-chair of the IRB would never probably get through any center. I was on IRBs in the military a lot too. Do the study, what would the study have to look like? You'd have to have 100 women who are pregnant. 50 we're going to put through the magnet. 50 we're going to keep out of the magnet, and then those 50 who went through the magnet, we're going to compare the outcomes in the babies to the kids who didn't get it. Nobody would allow that study to probably happen, right? But of all the studies that have been done on women who are pregnant, so I think it's on a risk-benefit ratio, right? Risk-benefit. So when you get her MRI, this is what her scan looks like. So on the right side is a normal MRI scan of the lumbar spine sagittal view, cutting the patient in half, looking at them from the side, right? The vertebral bodies are stacked one on top of each other. The discs are here. And then here's the first one, right here. And so this would be like a grade 4 anterior listhesis. And this is one of the cases that went through the musculoskeletal imaging series. And so anytime those cases were published, the PT submitted them. We had 4 musculoskeletal fellowship trained radiologists who would review the cases. We'd ask for the entire scan, the reports, and to make sure that the captions, the figures, the legends were legit, and the films were legit. And so this one here is blew these guys away, right? Because you have this monster study here. Here's caudal point, right? So here are the nerve roots. So she has bony compression between the posterior aspect of the sacrum and the posterior elements of L5. And so what's she at risk for? Caudal poina, for sure, right? And if you look at the position of these nerve roots, right, how posterior they are, you'd be concerned about putting a needle into her spine, right? So if you think about where this epidural would go, right, it goes through like 1 or 2, level 1 or 2, and providing that anesthesia from that point down to allow the childbirth to be a little less painful. Right, so this is a case that went through JLSPT, as I mentioned, and so they did, if you read the last paragraph, they did what they call prophylactic cesarean section. So they took her to the OR suite, right, under general anesthesia, and they delivered the baby that way. So mom and baby were both fine. Mom and baby were both fine. Interesting case, because how this patient had no low back pain for all those years is amazing. Because if this patient has low back pain, they do a scan, what are they going to say is the cause of her symptoms? For sure it's going to be this, right? For sure they're going to say it's going to be this. So she comes back, right? So this is a nice case. So she comes back 6 months later. Baby in the little carrier. You have one of those nice wicker baskets with you with a couple bottles of wine, water crackers, the high end, right, sausage, right? Nice cheese. Thank you so much for all you did. Look at our beautiful baby, right? That's wonderful. Good luck. Take care. How's your back? I have no pain. I'm doing great. Is there anything else I can do for you? Yeah, can we sit down and talk to you for a few minutes? Husband's there. So what it basically came down to was the husband said they were, if you look at this, if you found out you had this in your back, how would you feel? And so the wife didn't seem as worried about it as the husband was, so they had seen two neurosurgeons. One neurosurgeon said, this should be fixed, even if she doesn't have symptoms. The other neurosurgeon said, leave it alone. Don't touch it. And I remember I had a discussion with the neurosurgeon about this. I remember them telling me a couple things about these nerves, and these nerves can scar down, right? And he said that these nerves are probably tethered and scarred. If you try to get into monkeying around with that, you could definitely do more harm than good. And trying to pull that thing back, right, you don't know what the outcome could possibly be. So in their mind, leave it alone. But let me ask you this. How would you answer that question? They're coming to you for a no kidding second opinion. We got one doctor who says, do surgery. Other one says, leave it alone. They're coming to you. What do you think? Now, let me say one thing.
Yeah.
If you're truly being asked for your opinion, right, you can give it. But I would say that sometimes we hear patients telling us things from physicians, right, like they said, I got a muscle strain in my low back. Now, we may say that's nothing to do with a muscle strain, right? It didn't do anything to strain muscle in the back. It's something else. If that's the case, I would say be very, very careful about creating uncertainty for the patient. That uncertainty could cause concern in their mind. Doctor said one thing, you're telling me another thing. Because it doesn't matter if she has a muscle strain or not, you're just going to treat her the way you're going to treat her. You follow me? What the doctor says, sometimes if you already heard that, it's not going to harm her to know anything different. It's kind of go with whatever they say. You know what I mean? Follow me on that? Because that doubt could definitely be a concern. There's no reason we need to do that. She's coming to ask you, what should I do with this? What would you guys say?
I'd say wait until you have symptoms and then get that addressed. Because currently you have no symptoms
No
right now,
symptoms.
so why risk going in and making symptoms? That'd be my
We mentioned this before with those large extruded discs. There are surgeons out there who will say treat that. Especially if there's caudal quine, or compression of caudal quine. You know you don't have it, because at some point it could develop. So treat it. So that's one take. Would anyone say anything different?
I've got more of a question. So if it's probably been progressive, right? Probably when she was however old when she got the initial injury, it
13,
wasn't quite
she
this
felt.
severe. So, and I'm not a surgeon, but it seems like instead of going in to fix it, you could go in to keep it where it is and not get worse.
Yeah, this is fused though. This is fused right here.
Okay,
So that probably is going to move it.
okay.
So what the therapist in this case was, and this is the reference that we have down here is this study that looked at these high-grade slippages in patients with low back. Now, if she developed symptoms related to caudal quine, you'd educate her on that, she has to have surgery. Right, that has to have surgery and has to turn around fast, so you educate her on that. But these particular patients, they had to have either a grade 3 or a grade 4, right? And mechanical low back pain, but not progressive neurologic symptoms. One group got surgery to stabilize it, the other group was left alone. Now, what group do you think did better? Left alone. Left alone did better. Significantly better. Right? Significantly better. Actually, a couple people actually died in the surgical group. Yeah, and so I certainly think what you said makes sense, but if you can, this is my push for this, and last time I'll do it, if you can somehow look up and see if there's a study out there, you know what, thanks for the basket, but I gotta use the restroom real quick. And then you do a quick search and see if there's something there that says this is an okay thing to do, right? Because now you've got a little bit of evidence on your side, you know, that can help you make a well-informed decision, right? So if you have the evidence, that sometimes can help as well. So any questions on this one?
Mike, we have a case right now, one of our therapists has a patient where the L5 vertebral body is sitting down in front of S1.
Really?
Yes, it created, she's had plain film initially. You're kind of looking, there's something weird about this. I don't know what it is, but what's on the AP, what's this thing sitting in front of the sacrum? Anyway, it's a little beyond this, but the caudate goes back up and over and down to the sacrum. And it's probably been like that forever. She has no back pain. Has medial thigh pain that probably is coming from her hip.
Yeah.
But it really is remarkable that.
It's unbelievable.
Yeah.
Yeah, this speaks to this complicated relationship between what you see on a scan, the relationship between pathoanatomy and the relationship to symptoms, right? And how I think it's really a concern, because if someone sees that and she has back pain, they're gonna do something with that. And like I said, the outcomes of those surgeries are not that great. Now, if she's developing caudate and this is, you know, what you have to have to discuss this with your patients, any bowel and bladder symptoms at all, when does she have to get to an ER? Any weakness in her legs, right? Has to happen fast, right? You probably have like 48 hours max, right, to fix that. Or else you're dealing with permanent urologic and neurologic concerns. One more case here. So, 58-year-old fella who had persistent, severe bilateral neck pain. So bad, pain was so, and just developed insidiously. So bad that he had to be seen in the emergency department. So he treated with Toradol, which is an intramuscular, non-steroidal, pretty powerful, and Valium. And 1 hour later, and those are powerful drugs, his pain was improved. Okay? So they discharged him, diagnosed him with a neck strain, although he really hadn't done anything necessarily. And he was instructed to see his primary care physician if the pain worsened or persisted. Okay? And so 4 days later, the patient goes to see his primary care physician. So he started with neck pain, right? Now he has neck pain that's radiating down both arms. He has numbness in his right thumb. And he also has some constitutional symptoms related to fevers and chills, dysuria, painful urination, and pain in his legs, myalgia in his legs. So he's definitely getting worse. Okay, he's definitely getting worse. Physical exam, he had decreased range of motion in the neck in all directions. And he was diagnosed again with a neck strain, and this dysuria, the fevers and chills were thought to be related to prostatitis. So he was treated with an antibiotic, given a referral to PT, and then a non-emergent MRI. What's the wait for an MRI here?
Just 2 or 3 days.
Oh, really? Pretty quick then?
That's the routine
Yeah.
duration now.
In this particular case, it was 3 weeks for the MRIs. To get for a non-emergent MRI, it was 3 weeks. Okay. And so he's going to see the PT. So over the course of the next 10 days, he had 3 PT visits. And the PT visits went from the first time he saw the PT was doing some manual therapy on his neck, some traction, things like that. The second visit, the patient came in and he had some gait issues, so he actually trained the patient how to use a single point cane, continued to treat his neck. The third visit, the patient comes in and he can barely walk. And he can barely walk. So the PT now goes from doing manual therapy on his neck on day 1 to treating the patient how to walk with a walker. Well, not good. So, right, 14 days after that visit, right, this is 10 days after seeing PT, he winds up going to the emergency department. The primary reason was that he couldn't walk. He's in a wheelchair and he can't breathe. Right? He can't breathe and he can't stand. Right? So you do an MRI on him, do an MRI, and I'll show you that scan here. So we got a normal cervical sagittal view, T2 weighted on your right, and then here's his scan here. Okay. And so when we look at this, if you're looking at the cord, you know, this is again sagittal view, so the patient's cut in half. We're looking at him from the side. Here's the cord here, and we're looking for this white. anterior and posterior, high signal, anterior and posterior to the core, which is the cerebrospinal fluid. Right? And so here's his cord, this is our patient. Here's his cord here, and you see any CSF signal anterior posterior to the core? You don't. So that would be severe cord compression. And then this is the abscess and the infection right here. Right? Here's the infection right here. That area of increased signal right there. We had infection in his neck, as well as severe cord compression. Now, what's the prognosis at this point?
Hopefully it doesn't get worse.
Can't get much worse, can you? I'm in a wheelchair and I can't walk. And so, emergency decompression with spinal fusion is performed. After several weeks in the hospital, he was referred to rehabilitation, a rehabilitation center with quadriplegia. The outcome of the case, no use of his legs, very limited use of his hands and fingers. He's confined to a wheelchair. He's held with most ADLs. So not a good outcome at all. And so when this was published a few years back, it was published in a physician journal, and they used it kind of a medical legal component here. And they would ask, you know, what's the plaintiff's view on this, which is the patient's view, and then what's the defense on it? So if you read the plaintiff's view, right, the patient visited his primary care physician. That's the second visit. Classic presentation of infection, and should have undergone an emergent MRI, right, which would show that the abscess was there, allow appropriate treatment and surgery before permanent damage occurred. The defense said that the symptoms weren't typical of a spinal abscess, and there really was no way of knowing this was going to happen. So if you were going to vote, who would you vote for? What's that? You're on the jury. You going plaintiff or defense? Plaintiff? Yeah, they voted for the plaintiff.
But I guess the question is, why wasn't the PT on that?
What's that?
Why wasn't the PT on that as well?
Or emergency room doc.
You're right. And when they broke the lawsuit down, who do you think was sued? 80% went, because this is how this gets shaken out. 80% went to the primary care doc, 20% went to the emergency room physician. PT wasn't even involved. I find it interesting.
Yeah.
It kind of tells you what they think our responsibility is with these cases.
Because he had progressive problems in front of the PT.
Absolutely.
Yeah. That's where it was really.
What's that? PT was doing most of his neck. So they voted for the plaintiff, and then they made this comment: zebras amongst the horses. You guys know what they mean by that? That the majority of patients you see with low back pain are horses, because we see lots of horses, right? But one could be a zebra, and that zebra is this patient. How common are spinal infections? They're pretty rare. They're really rare. In fact, how many of you have actually seen a patient who's come to you for mechanical neck pain, or thought to be mechanical neck pain, was actually caused by an infection? 2, 3? 3? So, and Christy, how many?
Probably more than 5, I would say.
Oh, okay.
So Mike, I guess if you're looking at the differential of this, it's really his progressive neurological deficit. It doesn't even matter what the source of it is.
Yep.
He had long track signs.
I got a couple
Sure.
of, no, you're absolutely right. There's a couple of points here, and so, this developed, insidiously over the course of a couple of days, right? So what his pain presentation probably related to was probably the infection. That's probably why his pain spiked. How long has he had this cord compression? And he worked construction. And so he was still working, and he didn't really have any functional limitations, which tells me again, this complex relationship between pathoanatomy and symptoms. That this guy had a compressed cord for how long? And it really wasn't bothering. So something spurred all this on. But I will say this, though. What caused the difficulty breathing? Because I think this was a cascade of events here. I think the long track sign showed up the same time he started dealing with all this pain. I think they both kind of showed up. At some point, they're gonna develop neurologic symptoms. So what caused the difficulty breathing? What's that?
That you could be developing sepsis and.
Could,
Or-
but the thought was that his core compression was worse at 3, 4, and 5, which innervates what? Diaphragm. So that was part of the reason that he had difficulty breathing as well. So I think, you know, and I don't know what the take is on this, but I mean, you can get patients who have this core compression, and the bottom line is that if they're not getting worse, some of these surgeons are gonna leave them alone. If they're not progressive, but once you start to see that progression, it's like that quadric visit, you have to intervene on their behalf, sooner rather than later.
Mike Frost.
Yes.
Just a question, I know that it doesn't matter at this point, but, you know, I know some of those are related to like dental procedures and things like that. I actually just have a friend who had that happen.
Dental procedure.
Like having the abscess after a dental procedure. Rarely, that's fairly common.
Been there 2 times.
So the tooth, but then they developed an abscess and went septic. Is that?
Did this happen?
Just a friend of mine.
Has this happened to them?
Yeah, not complete paralysis like this patient, but had sepsis, had osteomyelitis. After, I think the only thing they can, he's a healthy, I think he's 62, very healthy, very active PT actually, to where the only thing they can relate it to is he had a dental procedure 5 days before. So, and woke up with excruciating neck, back pain, and it kind of progressed. He was hospitalized for 12 days. That's the only thing they can relate it to, and I know that that's also another kind of risk factor. I was wondering in that case, was there anything?
And you don't know, but you don't know. And, you know, but I don't haven't put them in here, I don't think in this talk, but, you know, there are times where you sometimes have trauma to an area, right? And a remote history of infection. And for whatever reason, with that trauma to an area comes blood flow. And if there's a remote history of infection, that blood starts to go to that area, and the infection can then generate from that. But the fact that it went to his neck.
That used to be one of Peter Borstein's lineup questions. If he thought somebody had an infection, he'd been to the dentist recently,
Yeah.
they give you antibiotics, that
Yeah.
kind of thing, and I don't know what the prevalence of that is, but it oftentimes shook out, for sure.
Absolutely. So, I'm gonna bypass this next case, but I just want to cover a neurologic exam just for a second, okay? And so, actually, you know what, I'm gonna cover this. Here, I'm gonna cover this one. And then we'll probably be close to taking a break for lunch and move into the afternoon session. But let me talk you through this one. This will lead us into the neurologic exam. We'll talk about the neurologic screen that I recommend that you guys do on all your patients. And that will preclude those things from happening. Because if the PT would have did a neurologic examination on day 1 with that patient, what would they have likely found? They would have probably found neurologic findings that would suggest that MRI needed to be ASAP and not what we call routine. Right? 3 weeks was just too long. Because if they got the MRI as soon as it was necessary, things might have been different in that case. But how could that PT go from managing someone's neck pain to teaching them to use a single point cane and teaching them to use a walker? That's just ridiculous. The fact that we're naming that lawsuit just pisses me off. What do you think? Because I used to do medical legal reviews for the military all the time, and I saw this a lot. I mean, bad things. Like, I can probably talk about it now, but we had a woman who had an epileptic seizure, got into a car accident, and actually dislocated both shoulders. Dislocated both shoulders. Now, she was a larger woman, and they determined that both shoulders were dislocated. The emergency room physician tried to relocate both shoulders, thought they were successful, never did follow-up films. Winds up going to see a PT now for severe pain in what they call bilateral frozen shoulder. Or saw the primary care doc, who now sends them to the PT. And I remember there were 4 physicians reviewing the case, because even though people think you can't sue the military, you actually can. And so there were 4 physicians and me reviewing that case. And so she was treated for almost 6 months with bilateral dislocated shoulders that she thought was supposed to be relocated. She developed frozen shoulder, severe pain. All the physicians they did not want to hold the PT liable. The PT saw her for almost 6 months. And they were like, this is all on the physicians. This is on the ER doc, it's on the primary care physician that she saw, and the follow-up visits were there. And I'm like, the PT definitely has a role. So what do you think? See her for that long? With that much pain? So, these cases get a little sticky. Let's do one more, clean up the neurologic system, and we'll talk about it more. The 20-year-old male, collegiate Division I football player, for actually the school that was on last night that lost, which is actually kind of interesting. Shouldn't give that away, probably HIPAA violation, something like that. But, Division I football player just got done with spring practice. So bottom line here is that he hurt his knee practicing for a bowl game back in mid-December, and now he's been struggling with this probably for 4 months. Spring practice is over. He's been diagnosed with this knee pain, patellofemoral pain syndrome. He's going back home, right, which is about 2 hours away, going home for spring break, and the trainer would like him to see a local PT to continue to manage his knee pain while he's at home, right? So continue to manage his knee pain. The patient says, you know what, I injured it 4 months earlier, I'm better, but, you know, it's still there, and it still bothers me. When the therapist starts to ask him some questions, he also notes that he has decreased standing balance, and he also has episodic headaches as well, which may or may not matter. Right, with MRI, the left knee was normal except for, and so this never got published. These images never got published, but here's a normal T1 weighted sagittal view of the knee. T1 because the bone is showing up right and fat showing up right. Here's the patella, right? Quadriceps tendon. Not sure if we're calling that a patellar ligament or a tendon anymore at this point, but this is a normal position of the patella. So if you look at that distal growth plate, the patella should sit right midway at that level. Here's his MRI. What would you say that he has? Patella. He's got a high riding patella. That was thought was causing his PFS. So we're doing some inferior glides, right? We're doing patellar mobilizations, taping, his hamstrings, quadriceps strength, etc. And so his body diagram, very interesting. So this is the one the patient completed. So if you look at, he puts a circle around his knee, dull, aching pain, but then he puts those lines in his foot. And he says, my foot is tingling. So I have this constant tingling in my foot, along with this constant pain in my knee. So that's kind of interesting, right? Tingling into his foot. And so the physical therapist now proceeds on with this exam. So this kid, and I'm going to tell you how he was walking, an 8-taxi gait with a wide base support. This is how the therapist, because I know the therapist says, demonstrated the patient's gait. This is what his gait looked like. This is what his gait looked like. And we started testing. Single limb balance, the kid couldn't stand for more than a second on either leg. He's got that with spring practice. He's a big kid. You know, about 6'2", 220 pounds. So when the therapist tested his muscle strength, the therapist was a little bit smaller, probably not strong enough. There might have been some weakness there, but the manual muscle testing didn't detect any weakness. Tested his reflexes, quadriceps, and Achilles tendon were brisk bilaterally. And then sensation, although he called his left foot, he had numbness and tingling there. His sensation was diminished through his entire left lower extremity and not during the whole attack. So the entire leg, just with light touch, couldn't feel as much as on the other side. So you started asking yourself, okay, am I treating that patellofemoral type pain here, or is there something else going on? Because I've had these patients before when I was in the military. Patient would come to the base, you know, they'd be there for 2 weeks for a training course, and we just continue on with their PT. And I'm gonna tell you, I just did what the therapist did 95% of the time. I give this therapist a lot of credit, because he could have just put the kid on the King Kong. That's an isokinetic machine, that's why he went there. The bills, by the way, 4 isokinetic machines.
Of course they do.
They use them all the time. You and I have had this conversation. They went by the wayside, but if I had one, I would use it.
Oh, yeah, I would too.
Yeah. Would you use it for testing and training?
For testing, for sure. 65 grand now.
I know. Bill's got 4 of them.
Base model.
They also got 2 cryo tanks too, that go down to minus 200 degrees.
Why do you need that consumer?
Can't wait for more than 2 minutes. So if anyone was looking for more than 2 minutes, there's someone out in California who shuts the machine off. But I walked in there and saw the facilities, I'm just like, this is just absolutely out of control. I can't believe it. They have all the players. So I went there and saw patients. There's actually a PT who works for the show. That's how we got to know. He was doing a master's degree in executive leadership for a business school, and he's a graduate of one of the schools in the area, and he's one of, I think, only 2 PTs who work for a professional sports team. And so he's not even a trainer. And he has a very, very interesting role. So he actually has patients that he sees on a routine basis. And he does no kidding PT. So I'm with him for 2 days, and I was like, you know, we don't do a lot of ankle taping and things like that. And we don't do a lot of modalities. He's like, these kids ain't taping ankles with me, and they're not. We have 20 trainers that can do that. So they're seeing no kidding patients. It's just amazing to me. So they have their juice bar that they take blood work on each football player once a week. And based upon their blood work, they put their smoothies together with their vitamin supplements and electrolytes based upon what their blood work shows.
We're getting that here in our
This is incredible. And then they have a special dietary section that feeds them directly based upon that same profile. Which is nuts. And then Josh invites the guys over his house every week for pizza and beer. You know what I mean? So that probably shoots that theory to hell. But anyways, let's go back to our person here. A couple other interesting findings here. So these are things when we start thinking about a neurologic examination. Should you be evaluating balance? You should. Should be looking at reflexes? You should. Should be looking at sensation? Right? You should. Right? L2 to S1, right? C4 to T1. Should you be looking at manual muscle testing, or at least a gross muscle screen? Absolutely should. Right? Should you be looking at special tests, right? Clonus. Should you be looking at Hoffman? Should you be looking at Babinski? You should. Right? So he had sustained ankle clonus on the right, 4 beats on the left, right? As well as the Babinski sign, right? So Babinski here, right? Toes up going is a concern, right? You want to be able to do that. And then the Hoffmans as well. So Hoffmans, right? You flick that middle digit, and you're looking to determine, right, is there flexion of the thumb and index finger? And if those things are present, what is that indicative of? Yeah, you're talking about either some concern over the brain spinal cord, right? And then, you know, and you ask him as well, he's having difficulty initiating urination. So you say, what's next with this guy? You know, and when do you need to pull the string on this? So they sent it to the emergency department, and I put this up here again, and I've had this conversation with a couple of neurologists over the course of the years. I'll be perfectly honest, prior to me coming here, I wasn't screening these things, and Michael gave us a lecture on it. Ryan and I, and Christy, I think, thought, it sounds kind of cool, but I'm not sure if this stuff really matters. Until we started going upstairs and started doing clonus and looking at Hoffman's reflexes, and then Ryan had a case that of a fellow who kind of came in. And this stuff just started to happen. We just actually got a case published yesterday. It's going to be in JOSPT cases. It was a young girl, 33 years old, diagnosed again with a frozen shoulder from an orthopedic surgeon. Saw a PT who really wasn't that great. Wound up referring the PT to a fellowship trained PT. We started doing a neurologic examination. All these things started to kind of come out. wound up having a herniated disc in her cervical spine and was compressing her cord. And that was what was causing her what she thought was her frozen shoulder. So, you know, I think what I'm telling you, I think with this neurologic examination, there's usefulness to it. But I've had this conversation before, that if you have a patient that shouldn't have an underlying reason for central cord symptoms. You have a patient with MS, you have a patient with a traumatic brain injury, you have a patient with spinal cord injury, they're gonna have these. Dealing with a patient who shouldn't have that, and a Hoffman and Babinski kind of show up, you need to get advanced imaging in the cervical spine, and if they're older, probably the brain as well. So in this particular case, the patient was immediately sent to the emergency department, where they wound up doing, and this happens sometimes, and sometimes, you know, when people see this, why would a physician order imaging of everything? Why would they order MRI of the cervical, thoracic, and lumbar spine? What's that? Yeah, and this patient that we just described, that I just described to you, the reason the orthopedic surgeon wound up seeing her back is he was convinced she wound up having urinary retention. So we sent her back to the orthopedic surgeon. And what do you think the orthopedic surgeon imaged, despite everything we told him? Hyperflexia, Hoffman, Babinski, right? Lumbar. Lumbar came back as normal. And we had to mention to him that this shouldn't happen. Well, she still has urinary retention. She still has long track signs. Would you consider doing an MRI of her cervical spine? And if I showed you the image, you'd say, it's kind of underwhelming, the cervical disc. It's not this massive herniation, it's just enough. And so they do all three because they're not sure, right? And you're probably dealing with the emergency physicians who pursued for something in the past, they missed something. And so we'll go ahead and take a look at the scans here. And so this is a normal. Sometimes you would ask authors to put a normal scan in. And so this is looking at the cerebellar tonsils, which are right here. And we're using a T1 weighted image here because the cortical bone shows up dark. Okay? So here's the posterior aspect of the foramen magnum, anterior aspect of the foramen magnum, and you draw a line right here. Draw a line, and that cerebellar tonsil should be superior to that line. Okay? And so again, we use this because you can see the T1 weighted image, everything shows up dark. Fluid shows up dark, cortical bone shows up dark, but the fat shows up bright. Here's his image here. So you can see the anterior aspect of foramen magnum there, posterior aspect here. If you draw that line, what do you know? Cerebellar tonsil is now permeated down into the foramen magnum. Does anyone know what that's called? Chiari malformation, very good. And so chiari malformation, so what has to happen here? He's progressing fast. Neurosurgeon was consulted, and the next day he wound up having the suboccipital craniectomy, and I think an L1 laminectomy as well. Suboccipital craniectomy and C1 laminectomy. And his symptoms resolved. Can he go back to playing football? Probably not. You probably shouldn't. But again, this is an example of when you see the cerebellum coming down, the compression there compresses the higher aspect of the cord, and you get those long track signs associated with it. A couple quick things here just about cervical myelopathy, this kind of leads into that. Right, so we're looking at the diagnosis here would be the sagittal view, T2 weighted MRIs. So here's the cord. We're looking at signal anterior and posterior to it, should be bright white. This is actually Ryan's patient here that we'd seen a long time ago, published a case. But this was a complicated deal because you see this rectorlisthesis of C3, a herniation between C3 and C4. This is ligament flavum here. You know, sometimes here it's called as buckling or thickening of ligament flavum. It is more of a buckling because you start to lose space between the discs. The ligament kind of folds down on itself, a little bit like a rubber band would. You compress it together. Could put compression on the cord, but the gold standard for diagnosing cervical myelopathy would be that cord signal intensity change. The cord appears bright right there. So if you hear the term osteomalacia in the report, that would mean that it's really been chronic for a long period of time. Okay, go back to this guy. you can kind of see, so here's what this cord should look like here, that dark signal. And you can see these patches of bright white. All right, that would be that same osteomalacia. Signified that means the cord is starting to die. And then, so just a couple of the quick findings here. I always like to look at these cadaveric specimens as well. So a normal finding would look like this here, where the cord would not be impinged upon. This would be more of a spondylitic case, right, where you start to get narrowing in the canal, right, by a variety of different factors. Could be hypertrophic bone, could be posterior herniations, thickening of ligaments, etc. And then again, I think when we start to think about, you know, what's going on here, we're looking for paresthesias in a non-dermatomal pattern, weakness in a non-myotomal pattern, and then changes in gait, right? Babinski, Clonus, and Hoffman's, those are those special reflexes that we test as well. They're consistent with long track signs. And then Romberg's a good test too. I'll mention these, and I think I might have got these from Michael back in the day, but I don't know if I got, did you put these slides? Did you share? These are interesting because these studies can't do these anymore. But these were like spondylitic models in a dog, right, where they develop cord compression through bone in canines. But then they sacrificed the animal and looked at the cord down the road. And what they found is that if you have anterior compression of the cord, right, the lateral columns and the dorsal columns get affected. And so when you think about what the lateral columns and dorsal columns include, and I think Michael did this slide too, because it's not necessarily consistent. And you'd say, well, why might a patient have maybe a gait abnormality, but strength's okay? Well, if the dorsal columns are affected, what's going to happen? Who's the dorsal column control? Does have some sensation? Dorsal columns? Dorsal columns. Proprioception, stereognosis, vibration, right? And so when you test something like Romberg, right, think about the Romberg test. You can do it lots of different ways, right? You need two things, at least 2 out of 3, in order to be able to function, right, with this Romberg test. So if I have an intact vestibular system, an intact vision, right, I may be okay. But once I close my eyes, if my dorsal columns are affected, what's going to happen? I've taken vision away, the dorsal column's already shot. The only thing I have left is my vestibular system. I'm likely going to have a positive Romberg, right? So don't dismiss those tests. And you can do them all kinds of different ways. That kid couldn't even stand on one leg with his eyes open, right? And so dorsal columns, that's going to affect gait. That's why we got to evaluate that. Cortical spinal. Motor. And I looked this up this morning. These not gait, but these bowel and bladder, especially bladder. And so cortical spinal could potentially influence the bladder. Because now we're talking about muscle that has now become spastic, right? If we're dealing with the cortical spinal, that's muscle that will become flaccid. That's not a cortical spinal tract in that case. Then spinal thalamic. Pain and temperature. So you could have patients with these weird, like our patient who had frozen shoulder, right? I have a sore shoulder, right? But strength's intact, sensation's a little bit sketchy, and now my gait starts to go too, right? And so if you're going to do a neurologic examination, you either have to do it all, or I'd say, don't do it. The reason is that of all of these findings here, many of them are probably more specific than sensitive. What do I mean by that? That if you have a positive Hoffman's or a Babinski sign, there's probably something there. Just because it's negative, right, it doesn't mean that you can rule this stuff out. And so if we had one test we could do, remember, we want to rule something out with confidence, it should be sensitive. Nothing here is highly sensitive. So that's why you have to do it all to get the full picture. So you're going to ask about non-disentainment on your patient. You're going to ask about balance. Right? You're going to do a segmental neurologic examination, thorough, great sensation DTRs, and then these pathologic reflexes are going to evaluate those as well. And like I said, you have to kind of do it all. And are you gonna be 100% certain if all this is negative that nothing's going on? You probably won't be 100% sure, but you can at least proceed with confidence of what you're doing, that it probably isn't there. Could you revisit some of this stuff? You absolutely could. You absolutely could. And so that's my last pitch for the nervous system. You know, when we start thinking about the red flag conditions for the neck, the red flag conditions for the neck, cervical myelopathy is going to be one of them on that far left-hand side, right? We'll talk a little more about cancer, upper cervical ligament instability. We'll talk a little more about vertebral artery stuff probably tomorrow, and then inflammatory disease and fractures as well. But these are the conditions that would cause you to be concerned and initiate referral. When's the referral need to be made? It's going to depend. It's going to depend. If you're concerned about a fracture in the C-spine, that has to happen probably today. If you're concerned about an infection, probably has to happen today. If a patient has some of these findings here, is it progressive? And if it is progressive, that probably needs to be evaluated sooner rather than later. Any questions on any of that?
Quick question, on the infectious ones, wouldn't like they have white count or something like that?
They probably will. Unless it's abscessed off, that's a really good question. And so if it's so if you have an abscess where it's kind of walled off, you may not see an elevated white count. But even sometimes that inflammation, I think, could elevate that white count. But once it breaks off and becomes systemic, those white counts are going to skyrocket. I think I actually have a case that shows some of that. Is the food here yet or not?
Not yet.
Well, keep going. So again, in terms of that neurologic examination, you're never going to be 100% sure, but I think you have to be more thorough with it, right? Because again, there's nothing there that if it's negative can help us rule out. So we're looking at the entire constellation of findings. I don't know, Michael, if you want to mention anything on that? Additional? Do you agree with that? Yes.
This might be kind of jumping ahead, but just based on the articles we read about like how we're trying to advocate as PTs to have direct access, I feel like there's a whole lot of PTs out there who don't know how to do a good neuro.
They don't.
Is that our job as a profession to then, if they're gonna go out and do a T out of their garage, do they need to be going and doing this like other testing to make sure that they're screening for these conditions? Or is that just something that falls back for physicians?
They're doing PTs in their garage.
Yeah, yeah, just like cash-based PT or something.
By the garage.
Hey, Mike, I have a table in my garage, actually.
I keep kitty cats out of my garage. I'm a proud member of the Animal Special Interest Group. The Animal Special Interest Group, I don't know why, focuses on canines and equines. And the felines, they don't care much about. Might take care of the kitties, a little thrust manipulation technique. Not the rotary one, just the gliding one. Work my way down. You guys think I'm joking? You guys could look her up. Her name's Teresa Southern. She's a veterinarian and a PhD, and she was one of the first patients I ever saw when I was a PT. I met her. She was a brand new lieutenant, tore her ACL. I treated her. This is 30 years ago. We wound up at the Air Force Academy again. She had a PhD in biology, but her and I used to do courses together, where she would kitty cat courses. She was a cat fan. Yes, and she would bring her a little, because sometimes the kitty cat could have to come in a cage. And can you imagine having 30 people bring their kitty cats to a course to learn how to, as PTs, learn how to treat kitty cats?
So that's why you talked about this all the way through your fellowship training.
So she would have her little doctor bag and give all these kitty cats a little sedative if they're a little rambunctious, and then they made the course great. You have 30 cats on the tables, and you can work with them. Kind of like a pelvic health course. Don't you have to bring your own patients? You have to bring your own kitty cat. Yeah. Yeah, so now you're asking a really, really good question. And I'm trying to deflect and trying to figure out how I'm just going to say that there is a lot of practice. There are. And I'm gonna tell you that when I talk to physicians, you know, and I don't know what your guys' take is on physician-owned practices, but we can't affiliate with them. And normally, it's orthopedic surgeons who own these practices, and we have a couple of Buffalo, and they probably provide the best care out of anybody. Their take on their PTs is this, that if I repair someone's reconstruct someone's ACL, and they can go see anybody they want, I don't know who they're gonna see. If they see a crappy PT, that means a crappy outcome, and that comes back on me. So let me hire top quality PTs to work in a clinic that I have. I'll give them all the equipment, everything they need, all the bells and whistles, but I know that my patients are gonna receive the best quality of care based upon who I interviewed, who I hired, and what's your philosophy in treating a patient with an ACL. But it's a crapshoot out there. No, it really is, and it's kind of sad, because you guys probably don't need to hear any of this talk. And, you know, what we just talked about, the neurologic examination, help a lot of patients. And we're presenting to you cases that really paint a really kind of a bad picture as to how things are going. But I don't know, I mean, patients, you know, go see a PT, and it's like anything, we hope for the best, right? We hope for the best, we hope for seeing someone good. That case we just talked about the young woman who had myelopathy, was interfering with her shoulder function. You know, the PT, good at all. And he had no idea about a neurologic examination. No idea. Now, should he know some of that? Probably shouldn't. But that's the case. I don't know if you want to comment on any of that. Subpar PT, subpar care. I mean, it's probably all professions, right? There's probably different types of physicians. Christie's dental friends here. There are probably varying degrees of dentists out there.
Well, I think we see it even within our Kaiser Permanente ranks. There's philosophically a lot of different ideas about what physical therapists should be doing.
Right.
And if something doesn't look right, it's like, go back to your doctor, you know.
Yeah.
There's not a lot of help.
The one thing I do want to say is that I'm gonna end on this. There was another case that was in here, but I'm not gonna present it to you. We'll talk more around it than anything else. But, you know, what I do want to mention is that we do see things like this, and I got a couple hidden slides here as well. But we do see things like this. So when in New York State, when we were trying to get direct access in New York State, the day of the actual vote that came out in Albany, there's a trade journal that's published every day for the legislators. This was on the back page, the last page of the newspaper for the particular day that the particular vote was supposed to take place. And do you think this paints us in a positive light? And then let me show you this. Like I said, I hid this. You guys don't have this one. But I recently found out about this. So this is from remember I mentioned about the American College of Radiology? The appropriateness criteria. So they originally were trying to get diagnostic imaging privileges in Iowa. And this is from the president of the American College of Radiology. Go ahead and take a read on it. Got it? What do you think the next page is going to say? We support our PT brothers and sisters? Or, looking into this, how long? Now this is 2023. This is pretty recent. What do you think the next page is going to say? How would you defend yourself to that, this ad right here? What would you say to this?
I think it might mention the training comparisons in musculoskeletal repair from a physician versus EA, physical therapist, like I think it might expand on the different training that I spent in that area.
Yeah, I don't think they have any understanding as to how much we actually do, but I will tell you this. You know, we tell our students this as well, that you spent a year, was it a hard year, musculoskeletal year? First year? And COVID hit during the second half. And COVID hit when I had to start teaching the spine and the hip. So poor Nicole got the spine and the hip online. And that's crazy because there's a Band-Aid that came out in Buffalo that we couldn't even, like, I brought a table home. I had to make videos on the fly. They gave us like a week to prepare. I had no videos. I had nothing made up. And I remember I was going to use my son as a demo because we couldn't. They said you can't leave the house, you can't, and then they said you can't even get close to people. We were going on campus and making videos amongst the faculty, and they said absolutely not. So I started with doing demos on my cat. Long access distraction on the kitty cat right here. You can do this as a grade 3 or 4, or you can turn this into a grade 5. Kitty cat. How do we scour the hip? Kitty cat in supine. There we go. So that's how crazy we were getting. I said, I gotta use the cat. And so, but I would tell, you know, our therapists that, you know, every year, and then you have that 516 class that you guys want to take in the spring, because we moved, remember that one? 516 class where we talked about thrust manipulation and stuff. And so you have a full year of musculoskeletal, a hard full year, and then one additional course in advanced clinical decision making. And so by far, your knowledge exceeds that of any physician or PA. Unless it's an orthopedic surgeon, we'll talk about this after lunch. But you could say that, you know, the training is something that, you know, that helps us get past that. What would you say to these guys from the American College of Radiologists?
Sue them for defamation.
Sue them for defamation. But they have a, I'll tell you how it was answered. So they have a reference on here. So they reference a study in JAMA that looked at the diagnostic imaging by non-physician personnel, NPs and PAs. And their main concern with this was that there was going to be an overabundance of diagnostic imaging coming from PTs. But when we start looking at PTs, especially in the military, who actually have diagnostic imaging privileges, they actually image a lot less than you think they normally would. And why is that? Because we just talked about how to do a neurologic exam. And you're doing that thorough neurologic exam, unless something is there that I told you is specific, right? That's when you get imaging, otherwise you're not gonna get it. We talked about Canadian cervical spine rule, how to a knee rule, how to a foot rule, ankle rule. But unless those things are there, you're not gonna get it. And so it's a hard time finding, you know, cases that relate to that. So how did the folks in Iowa defend against this? This one took a vote. They cited how much education nurse practitioners and PAs have, and the fact that they're not educated doctoral level. And they showed what PTs are trained at. Once the legislators heard that, they voted unanimously to give them, and they have the full kit and caboodle in Iowa. So they have plain film, CT, MRI, nuclear medicine scans. They have the whole show. Anyone else want to comment on your subpar PT friends? I think that as leaders in the field, you know, education things that I talk about in these classes are data driven. So we're gonna spend time on cardiovascular screening, we're gonna spend time on screening for diabetes, we're gonna screen for talking about depression. We just completed a study about PT screening for yellow flags. How do you think that went?
Not good.
Not good at all. Well, things are probably better, or not good at all. And we just published a paper in the Orthopedic PT Practice Journal that looked at the auto and knee rule and how well PTs did on a standardized exam compared to emergency room physicians. And we did a little bit worse overall. Board-certified PTs did a little bit better. But all we have to show is that we're close to physicians. That's all we got to show. And the more that data kind of pops up, you're going to see that. And that's why I gave you guys that Katie O'Brien paper, because she highlights a lot of different papers that talk about that type of stuff. The one thing I will say is that when I give you guys Gale Dow paper, I gave you guys that. So the Gale Dow paper was in direct opposition to this. And how did Dr. Dial say that we should be screening for patients who potentially have cancer? Did you read it? You guys read this? One long page. Anyone got a copy? Anyone got a copy of it?
Yeah.
Take a lot of notes, so I'm pretty impressed. I'm pretty impressed. Anyone got the paper? Oh, we're waiting for pizza. I can just keep going here. Is it pizza? Is it here?
Just,
I just want to cover this real quick. No one read Gale Dow's paper. Oh, here we go. How's your reading voice, sir? All right, so listen. This is in direct response to that ad from the New York State Society of Orthopedic Surgeons. We're going to read paragraph 3 on page 633. We're going to read paragraph 3. And listen to what's being said here. This is about trying to rule out cancer. We're talking about cancer in a patient with musculoskeletal pain. Go, sir. Nice and loud. Go ahead, stand up and orate to the crowd. This is important. If you guys can understand these two paragraphs, right there, if you guys can understand these two paragraphs, you've got a good leg up on the majority of the PT population, I think. Go ahead.
While the risk of a tumor in the low back is therefore quite low, physical therapists are thoroughly educated in evidence-based diagnostic strategies to recognize non-musculoskeletal problems. Best evidence screening strategies suggest that spinal tumors can be ruled out with 100% sensitivity if the patient is less than 50 years old, does not have general health changes such as unexplained weight loss, and does not have a history of cancer, and is responding to conservative intervention.
Key words there. Dave, what's the key word or words that Dave mentioned?
responding.
Sensitivity, but what level of sensitivity? 100% sensitivity. So, what did Dave just say? He said that if the patient doesn't have a history of cancer, they're younger than 50, they're not losing weight or exhibiting other general health signs, and they're improving, right? What do we say we can do? Rule it out with 100% sensitivity. We don't have many things in our practice that we can rule out with that level of certainty. So, do you have history of cancer? No. That's good. Younger than 50? No. That's good. Why? Because I don't know, once you hit 50, stuff gets good. Like, every day I wake up, it's like a new freaking thing. Like, literally, I tried to clean the refrigerator out the other day, and I tried to squat, and all of a sudden, my left hip, I'm like, I can't even squat. Left hip got better. Right hip was bothering me yesterday. Right knee was bothering me this morning. It was pretty bad pain. I'm like, what the hell is going on here? Let's not even talk about other things. There's pretty going on.
I was wondering your relationship with Jack. Is that plenty of
Yeah. doubt it. Maybe he's my only friend. But anyways, think about this. No cancer, younger than 50, because once 50 hits, that's a risk factor. That's legitimate. The risk starts going up for everything. No weight loss, and they're getting better. You rule out, but what if one of those is there? Let's say you're older than 50. And maybe you got a history of cancer. Read the next paragraph, Dave, if you wouldn't mind, go ahead and stand up, nice and loud. Listen to the next paragraph, because one of these is present. How many of you treat a patient over 50? Yeah, so there's a risk factor, so now they got a risk factor. Now you're concerned. Go ahead and read it.
When red flags are present, evidence-based screening strategies for spinal tumors are simple and do not require the consultation of a surgeon. Simple imaging and laboratory tests like AP radiographs and ESR can rule out spinal tumors with 100% sensitivity.
Keywords there. 100% sensitivity. So if you want to rule these things out, so I just went out, I'm not saying I don't know why they asked me, but I went out to Arizona and taught a 2-day course. One day was on medical labs, the next day was on medical screening, because they are the first state to have PTs who can legally now order medical labs. First day. That's good. And they have imaging now, they have medical labs, and they're gonna look at trying to get a limited formulary for non-steroidal medications as well, and muscle relaxers, just like the military does. Very interesting. So if one of these shows up, if you get a SED rate, and radiographs, and those are negative, you can rule it out. Does anyone know what a SED rate is? It's an old school test. The newer test is like a C-reactive protein. It's just a measure of general inflammation of the body. And if it's less than 50, right, it's less than 50, you're confident that there's not cancer. But you have to partner it up with radiographs. Now, how are the radiographs negative? We already said that. Things are going to show up on a radiograph that are going to look kind of nasty in most patients. What we're talking about here are no what we call lytic or blastic lesions. No lytic or blastic lesions, and what is that? If we do a plain film, a lytic lesion is going to relate to where we see bone being broken down. Lytic, broken down, blastic, bones being built up. And these are not normal pathologic, these are not normal physiologic processes. So in this particular case, these are section cadaveric spines who had visual metastatic disease through the spine. You can see the metastases here, right? You can see it. And then they took plain films of these. The study was about asking radiologists at what point they can see changes on diagnostic imaging. So these would be lytic lesions right here. Why? Because the bone's being broken down, and when bone's being broken down and less dense, how does it appear on a radiograph? Black or darker, right? Radiographs are all about shades of gray, right? Increased or decreased radio density. CT the same way. MRI deals with signal. High, moderate, or low signal. High signal, things are really, really bright. Low signal, things are really, really dark. But here, these are lytic lesions. What would this be down here? So look at the degree of metastases in this vertebral body. What's going on here? It's blastic because it's being built up haphazardly by pathologic bone, right? By pathologic bone. So now it's showing up whiter or brighter. So if you have a lytic or blastic lesion, that rules out that X-ray. So we're looking for absence of lytic or blastic lesions. What's going to happen to this vertebral body over time if, let's say, the patient was alive and you have lytic lesions and they're compressing? What's going to happen to that vertebral body? It's going to fracture at some point. Yeah, it's going to fracture. So we're also looking for pathologic fractures. And so this is how, like I said, when we talk about how we got through New York State, talk about this. This is a simple screening algorithm. And again, even if you can't order these things, the primary care doctor can. What's the genesis of this though, really? Why did they do this? Do they really think that you guys can't do this? What's their opposition to direct access?
Finances. the
Money.
cost.
It's about money. Yeah, it's about money. Because lots of orthopedic surgeons make a lot of money about, the conservative management of patients. Diagnostic imaging, injections, things like that aren't necessary. This is related to cost. I'll be honest with you, I don't know about that American College of Radiology stuff. I do know that study that they cited was absolute garbage. That's why I circled it, and you can look it up. It's interesting though, because there really were minimal differences between, in fact, I don't know if I can get online or computer, but there were very minimal differences between the imaging tendencies, PAs and activity, like within 1%, so I don't know what to say. But got past it. So you guys are on the CEO's radar, American College of Radiology. Pizza ready? How long do you guys need for pizza?
How long do you want to, it's really lovely out, people want to get some budget deals.
Vitamin D. You don't have to go to Buffalo for like a year.
I know.
How long do you want to give people, how long are we going for?
Decide, I told them 5.
Okay, we'll go 5. You want to give people an hour right now?